Hello everybody, good afternoon. Welcome to our 6-month progress report. My PhD is titled New Perspectives on Transplantation in the Treatments of Cancer and Diabetes. So my name's Arnold Marchis. I'm a graduate of Biomedical Sciences and also a fresh medical doctor, and currently a first year PhD student and a master's student. This is my team, who I'm very happy to see most is here today, and we have a new international collaborator from Manchester, Professor Titus Augustine. Our vision is to offer the best medical or surgical options to cancer and diabetic patients and improve the level of healthcare offered in Eastern Europe and more. And our mission is to learn from the very best in the field, find knowledge gaps, improve current standards and policies for the treatments of cancer and diabetes. So we have 2 projects. The first began in September of 2024 and the second one in November. So without further ado, the first project is entitled Comparing the Effect of Pancreas and Islet Transplantation to Insulin Therapies on Glucose Metabolism in Patients with Type 1 Diabetes Undergoing a Renal Transplant. This is a systematic review and meta-analysis. So, background. Well, diabetes accounts for about 45% of chronic kidney diseases, and around 40% of diabetics are actually listed for renal transplantation in some countries. There are currently multiple options that may be combined with renal transplantation. You can consider pancreas or islet transplantation as the only cures for type 1 diabetes. They are the only things that can induce insulin independence. Interestingly, up to 96% of pancreases are transplanted either simultaneously or after a kidney. Pharmacy and technology are both industries that are advancing at rapid rates, and that's with good reason, because diabetes is set to grow exponentially over the next 20 years, as you can see on the figure on the right. So, looking at these figures, the first one shows a pancreas transplantation, the second illustration is of an islet transplant, and the figure on the right shows a very nice and nifty device which represents a modern form of insulin therapy. Our aim is to determine which newer therapies can improve glucose stability and other outcomes. So, the population: type 1 diabetes patients undergoing renal transplantation. The interventions will be pancreas transplant, islet transplant and insulin therapy. And our primary outcome is glucose metabolism in the form of HbA1c, but we'll look at many other parameters. And we have multiple secondary outcomes such as renal function, cardiovascular parameters, overall survival, graft survival. So, is pharmaceutical intervention combined with renal transplant superior to double transplantation in patients with type 1 diabetes? Well, we hypothesize that less invasive methods are not inferior to invasive methods. So what's the clinical and potential research implication to this? Well, the level of surgical need for type 1 diabetic patients may decline in the future. So this is our systematic search key. The first domain refers to the patients with diabetes, the second to the renal transplantation, and the third domain refers to the accompanying therapy. This is our flowchart selection, and we got down to 309 full texts that were eligible, and we are still trying to retrieve a few. So, the first topic, well, it's feasible, registered, we've removed duplicates, title and abstract selection, full text selection is done, and due to the volume of the project, we split data extraction into 2 rounds. The first round is the extraction of the numerical data, and the second round will be the extraction of the graphical data, Kaplan-Meier curves, spot plots, so far and so forth. So we're very lucky that we have some figures to show already from the numerical data. So here we have 11 studies that basically show the baseline versus the 12 months of HbA1c levels following a simultaneous pancreas kidney transplant. These are single-arm studies, and as you can see, statistically and clinically, this is significant as HbA1c levels reduce by about 2.59% in terms of HbA1c after 12 months compared to baseline, actually showing that this induces insulin independence for these patients. There is, of course, some heterogeneity that I have to address. This is statistical heterogeneity, probably due to the number of patients in each cohort. The HbA1c levels before the operations would happen. Of course, this differs from year to year, from country to country. And we have another plot which shows SPKT in comparison to kidney transplant alone, or in other words, I'd like to call it kidney transplantation with insulin therapy, because it's never alone. So here we have a difference of 2.16% in these patients who receive SPKT transplantation. And the conclusion of this plot tells us quite nicely that SPKT could decrease the HbA1c by 2.16% compared to kidney transplant alone after 12 months of follow-up. Of course, with the amount of studies that we have, there are many more plots to come, and hopefully soon. Our second project is comparing liver transplantation to systemic and regional therapies in unresectable hepatic malignancy. So background to this project. Well, the liver is the most common site for metastasis. It's actually more common to have liver metastasis than a primary hepatic cancer. Up to 50% of colorectal cancers develop colorectal liver metastasis at some point. And the liver is the most common location for metastasis for many other forms of cancer. Up to 80% of metastasis cases are confined to the liver. However, the majority are considered inoperable. Liver transplantation is an option for unresectable primary or metastatic cancers in the liver, even though going through medical school we might learn the contrary. So sticking to these figures, I'd like to tell you what our aim is. Well, we want to assess the effectiveness of liver transplantation in different oncological diseases. And you might ask, well, why, if we've been taught at medical school that cancer patients are probably not the best candidates for liver transplantation? Well, some very recent studies show that they are, and based off some very old criteria actually coming from the 90s. Milan criteria, for example. There's also San Francisco criteria. So, clinical question. Is liver transplantation the best option to treat patients with inoperable cancer? Our hypothesis is that liver transplantation is the best option for treating some forms of inoperable liver cancer. So overall, our population will be patients with inoperable liver cancer, the intervention transplantation, and we'd like to compare it to other forms of therapy that are very well established, such as chemotherapy, radiotherapy, and our primary outcome will be, of course, overall survival. So you might be asking, what's the research implication to this, or the clinical implication? Well, it all comes down to the fact that more patients with unresectable liver cancers could be placed on transplant waiting lists in the future, ultimately giving them a second chance at life. So we have a preliminary search key with 4 domains. The first domain refers to the liver neoplasm, the second to the transplantation, the third to the comparative therapy, and the fourth to the outcome. There are a few Prospero-registered studies that are looking at a few of these forms of cancer, but none that include all the ones that we want to include. So we have some key articles that are split into 2. The top part look at colorectal liver metastasis specifically. The second part look at primary hepatic cancers, and we'd also like to add neuroendocrine cancers to that, neuroendocrine tumours. So the topic is feasible, and it's not yet submitted on Prospero. In summary, we have 2 ongoing projects. The first one, we're still optimistic that we'd like to submit in June, and for the second project we have set a deadline for February 2026. So I'd like to finish on a quote that a little science distances you from God, but a lot of science brings you closer to Him. And that was said by Louis Pasteur. Thank you very much for your attention. Open for questions.
So first of all, congratulations for your work. Your progress is amazing, taking into consideration the tremendous number of the included articles. So I have a question regarding your first project. I'm assuming that you will soon start the risk of bias assessment. So what are your initial thoughts about the biases in these studies?
Yeah, so really good question. Of course, so going back to the first plot, 4 of those were RCTs, 3 of them were prospective, a lot of them are retrospective. I don't think all of the articles will have a high chance of bias, but there definitely will be some. That's the truth. Thanks for your question.
Thank you very much.
Yeah, we're going to start that very soon, so I'm curious to see how many, top quality articles we'll have in the forest plots. Thank you.
Great, thank you.
So I have a question. You already addressed that you have a quite high heterogeneity, like statistical. So do you have also clinical heterogeneity there?
Yeah, that is a very, very nice question. So if you think of it from a surgical point of view, older pancreas transplant used to be segmental. Now they are en bloc. They include the duodenum as well. And then you have to think of the types of anastomosis. The anastomosis, so the drainage can be done into the bladder, or it can be done enterically. And then you've also got the venous anastomosis, which can be done to the portal vein, to the iliac vessels, for example. So in that sense, yeah, surgically. In another sense, in terms of heterogeneity, I would say that there's heterogeneity between all the studies, because there's I don't think they all perform the study in the same way, which is absolutely normal. Yeah, that's what I can think of off the top of my head. So, yeah, it's a good question. Thank you.
Thank you.
I have a question. Hello. I'm just curious. Based on the last 3 months, that there are any realization that you had about the first project that stands out?
Yes. I would have hoped to see more articles comparing modern insulin therapies to the established ones, so to the transplantation therapies. Unfortunately, that's not the case, so it shows that there is a serious gap in knowledge when it comes to this. In terms of realizations, I would say that there is a lot of research to be done in this field, and it's even more exciting than I would have thought it was 6 months ago.
Very nice presentation.
Right, thank you.
I'm interested in your thoughts about the liver organ shortage. Because there's not enough livers for everyone. So I'm just interested in your thoughts on the ethical part. So is it ethical to give oncological patients healthy livers when there are cirrhotic patients with PSC, etc., on the waiting list for years? So what is the balance? Who do you want to give? Who do you want not? It's just a thought.
That is a very good question. So ethics is a subject that gets brought up constantly with these types of transplantations, because a lot of medical professionals might think, well, that it's going to be a waste. It's going to be a waste of a liver that you could give that to somebody else, and it's almost certain that that person will live happily ever after with that liver. However, I do still think that there is a way to be able to save these patients as well. And looking at the overall survival following the liver transplantation, I'm very optimistic, because we're not having the same results as we did before, because medicine's evolving, it's changing. So the forms of immunosuppression are different now. So these patients actually are becoming very feasible candidates, but ethics, of course, yeah, you have to take it into consideration, and it's a very good question.
So we can cure the HBC now, and we have a brilliant vaccination against HBV, and it is predicted we have more and more liver to transplant, and this is the background of this idea. So in the next years, in the next decades, we have more and more liver based on this idea.
Yeah,
Okay.
so, and sticking to the availability, just one more point, sticking to the availability of livers. Of course, if you manage to train enough medical professionals and you manage to change policy in a certain way, because in some countries, when it comes to donation of organs, they have some very well-established policies, but I think other countries are not quite there yet. So I think a lot of it will come from policy when it comes to availability, which therefore could resolve some of the ethical questions.